Greetings, everyone. I'm Tom Callis with Invitae. On behalf of the SADS Foundation and Invitae, I would like to thank everyone for joining us today for today's presentation from internationally renowned inherited arrhythmias expert, Professor Silvia Priori, on the latest diagnostic and treatment strategies for catecholaminergic polymorphic ventricular tachycardia. Before we begin, I had just a couple of housekeeping items to mention. Please submit your questions for Professor Priori anytime during the presentation by typing them into the questions pane of your GoToWebinar control panel and clicking send. After the presentation portion, I will read them aloud to Professor Priori. Also, I'd like to remind you that today's webinar will be recorded and will be available for later viewing on both the SADS Foundation and Invitae websites. Professor Priori, we thank you for your presentation today, and we've been looking forward to it.
Thank you very much. Good morning, everybody. I'm speaking from Italy today, and I will be discussing with you an update on the diagnostic and therapeutic strategies for catecholaminergic VT. So let's start from the beginning to review a little bit, the diagnostic definition of the CPVT. CPVT, first of all, is important because it is one of those inherited causes for juvenile sudden cardiac death. So when we have patients with this diagnosis, we have to keep in mind that they are actually individuals at risk of death, even if when we see them and when we establish the diagnosis, they are completely asymptomatic. The triggering factor to precipitate the arrhythmic events that lead to sudden death are emotion and effort. In a sense, CPVT is similar to long QT syndrome, where again, also in long QT syndrome, we have that emotion, stress, physical activity, are really the factor that initiates and maintains the arrhythmic event that may spontaneously terminate, or they may actually go on and develop a VF and lead to cardiac arrest. But at variance with long QT syndrome, this disease does not lead to the typical arrhythmia of long QT syndrome, that is torsade de pointe, but it leads rather to bidirectional and polymorphic ventricular tachycardia, and we will see a lot of examples of these arrhythmias during the talk. So in these patients, we have an absolutely normal electrocardiogram and normal echocardiogram. So it means that the electricity propagates in the heart in a normal fashion, so that all the intervals, PR, QRS, TST, QT, are of normal morphology and duration. The fact that also the echocardiogram is completely normal in this patient leaves us with the question, so how we can identify this patient? And the question is that, as you see in the slide, that there is a major diagnostic value of exercise stress test. Unfortunately, exercise stress test is still perceived predominantly as the test that is done in patients with coronary artery disease. While we have to keep in mind that in young people having syncopal events during stress or exercise, or reporting palpitations, arrhythmic heart during stress and exercise, they should undergo an exercise stress test, exactly because this disease cannot be diagnosed with any other methods of diagnostic cardiology. So here you see an example of the electrocardiogram, and I choose this example because, in fact, as you see here, these patients sometimes tend to have quite prominent U waves. This is not something that is constant or present in all the patients, but is a sort of a minor diagnostic criteria that may be taken into consideration when we are seeing these patients, especially at the initial assessment of these individuals that are referred to us. So if we have to think in which context we actually see patients referred to for some reason to us when we should suspect the CPVT, besides what I've already said, that are patients fainting during exercise and emotion, or patients reporting in the same setting palpitation, irregular heartbeat, shortness of breath, we also have, unfortunately, that some individuals previously completely asymptomatic may have, as a first manifestation, cardiac arrest. So also you have to keep in mind this potential diagnosis for the individuals that have been resuscitated in young age from a sudden cardiac death without clear causes. And especially when the patients come to your observation and they already tell you everything looks normal, there is a good reason to suspect that the patients might have CPVT if the event was precipitated by one of the triggers that we have already discussed. So when we put these patients on the treadmill, it is very important that we look at different things about the rhythm in which these patients are. So first of all, we have to keep in mind that despite our attention is always focusing on the ventricular arrhythmias that may develop in these patients, as you see here, they also have atrial arrhythmias. And actually, supraventricular arrhythmias are often on the treadmill the first manifestation, and then the ventricular arrhythmias come a little bit later. Now, there is another factor that is quite interesting and has to do with the pathophysiology of the disease, is the fact that there is this reproducible onset, the profile of the moment in which this arrhythmia starts, that is very much patient-specific for what concerned the heart rate at which the arrhythmia, either atrial, ventricular, or both, start. Usually, you need to get up to 910 beats per minute before you get these arrhythmias. So this also accounts for the fact that if you have bradycardic patients, like some athletes, you may have that the fact that having a slow rate to start with, they can exercise for quite a few minutes before they actually start manifesting the arrhythmias. But once you have a threshold, you will find that when you see these patients over and over at follow-up, in the absence of changes in medication, they tend to have this threshold that is quite reproducible. And therefore, you will be able to anticipate that after a few minutes, when they reach their triggering heart rate, they will start having the arrhythmias. Sometimes you will see that the patient himself knows that at a certain heart rate, he or she starts having arrhythmias. Now, the ventricular arrhythmias that are most typical are either polymorphic VT or bidirectional VT. And as I said, some of the patients never really develop this bidirectional or polymorphic VT, but their arrhythmia is predominantly ventricular fibrillation, which is, of course, a big clinical problem. So on this slide, what we are seeing on the left panel is the presence of bidirectional VT. So you see ventricular beats of two morphology. This one I'm pointing to with a positive QRS, this one with a negative one, and then is another positive and a negative. And this is the very typical arrhythmia that occurs in CPVT and in not many other conditions. So you don't have a lot of differential diagnosis. The most common differential diagnosis in terms of the fact that it's a condition in which often you may see bidirectional VT, but is rare because it's a rare condition, is the intoxication with digitalis. And the reason why digitalis intoxication leads to this arrhythmia that is also present in CPVT is because the electrophysiologic cellular mechanism for the onset of these two arrhythmias is called delayed after depolarizations and is common to the two, even if one is a genetic disease, the other one is an intoxication. In this other panel, what we see is that actually in the patients with CPVT, what you expect is that when you start having the patients exercising, you may see a mixture of electrocardiographic changes with different arrhythmic beats. You may have supraventricular beats, ventricular beats. You may have even short runs of atrial fibrillation. So sometimes the interpretation of the arrhythmic pathway on the electrocardiogram during exercise stress test is quite complex. So I mentioned a little bit of the mechanism. We definitely will go back and discuss that more carefully. But right now I'm drifting your attention to the fact of, is a genetic disease, so which are the genes that cause this condition? So the most common, the most important, as you see here, the one that accounts for the majority of the defects identified in these patients is the cardiac ryanodine receptor. The cardiac ryanodine receptor is this protein, the brown one with the green dots. This is an ion channel, is a very large ion channels that does not sit on this layer that is the membrane of the cardiac cells. Here you see, for example, a calcium channel. So most of the channels we used to work with in electrophysiology, the one that targets drug like calcium channel blocker, potassium channel blockers, these are all channels that sit in the membrane. But the ryanodine receptor sits in a different membrane, that is the membrane of the sarcoplasmic reticulum. That is the area in which calcium is stored. And the ryanodine receptor is the channel that releases calcium to allow contraction to happen. And the reason why a channel that regulates calcium, that has as a final goal the control of contractility, ends up leading to arrhythmias is something that we will see in a moment. I also want to point your attention to these other orange-shaped lines and all these calcium dots, because these are a graphic representation of calsequestrin. Calsequestrin is a linear protein, means that it creates a mesh in which calcium binds, and actually is a reservoir of calcium inside the sarcoplasmic reticulum. But calsequestrin is also a regulator of the ryanodine receptor. That's why it ends being the second major gene of catecholaminergic polymorphic VT. Now, the mutations in ryanodine receptor cause a dominant form of CPVT, while in calsequestrin defects, you see them in patients that are homozygous, so is a recessive disease. Then there are also these other two genes that should be considered, triadin and calmodulin. And especially calmodulin is a recently identified gene, so we don't know right now the actual real prevalence. We say rare, but it might be just because there is recent that this gene has been identified. And both triadin and calmodulin end up also modulating the ryanodine receptor. So from a functional point of view, we have to think that this function of the ryanodine receptor either caused by mutation that directly modify the protein or indirectly because of the effect of other proteins that binds to the ryanodine receptor or regulate it are responsible for CPVT. This is to show you, one family pedigree, and this is not just one of our family, it's the family in which we discovered that ryanodine receptor is the gene that causes this CPVT. You see that in this family, we had all the children of this affected mother had inherited CPVT, and 2 died around age 10 and 12 during conditions of stress. One coming back from school, the other one and running up the stairs, and the other one being in class and having the teacher pointing to her to get an answer. So quite unexpected and tragic death. But you also see that being a dominant disease, you may have quite a few cases in the family. And this is important because it points to the fact that genetic analysis is very, very important in CPVT. It's even more important than some of the other channelopathies of cardiomyopathies, because you have on one side a disease that is very difficult to diagnose on the electrocardiogram. Actually, on the electrocardiogram is impossible. You need to do the exercise stress test. But and on the other side, it may be highly prevalent in family members when you have large kindreds, and it's so much easier to have the mutation and screen everybody and call back for your clinical evaluation only the one that are affected, that really you should consider genetic testing as a very, very important tool and resource to establish your diagnosis of CPVT. Now, on the right, you see the panel that shows how this bidirectional VT is very reproducible in all the family members that are affected. So individual generation 3, subject 3, You know, you see this person is the problem in generation 3, but patients in generation 2, and they are all manifesting this positive, negative pattern. That is the typical one. And this is the mutation that we have identified in this family. So now here is just to give you the physical concept of how the ryanodine receptor is this channel, you see, made of 4 units. So the genes actually encodes one of these units, and then 4 of these proteins get together. They create a donut-shaped structure with the hole in the middle where the calcium goes through. And therefore, you know, the channel is the one that is actually controlling the calcium, but also controlling the rhythm, because the amount of calcium that goes in and out at the end also influences the electricity. How the mutations lead to this abnormality in the release of calcium is very debated. One hypothesis is that these blue balls that are here represents a protein that actually stabilizes the closing state, the fact that the channel closes during diastole, and so calcium doesn't flow during diastole. When you have a mutant channel, this protein that keeps the channel closed does not work well, and therefore you see that also in diastole the calcium can flow. Another hypothesis is that the abnormal protein, instead of folding nicely in the shape that it needs to have to be able to open and close tightly, and therefore when closed do not allow other passage of calcium, when it's mutant is not able to be a tight structure, becomes loose, and therefore leads to calcium release in diastole. Another hypothesis is that the protein, the normal protein, is made in a way that even the maximum level of calcium is not causing leakage during diastole. But when the protein is abnormal, the threshold for releasing calcium is lower, and therefore during exercise, you know, what happens is what is shown down here, that the threshold is below the level where the calcium goes during exercise stress. And so the protein is simply less able to contain the increasing calcium that occurs during exercise. So all these things are basically saying, you know, that we may have so many different mutations in CPVT that when you get your genetic results, you see recurring different mutations in different positions, but at the end, they all lead to conformational changes of the protein that make the channel unable to stay closed properly and therefore to generate these arrhythmias in your patients. This is just to show you, you know, I mentioned that the arrhythmias are the same arrhythmias that we see also in digitalis toxicity mediated by delayed after depolarizations or DADs. And I would like to help you remember, you know, what is the link between releasing calcium that ultimately is released to allow the contraction, how this creates an arrhythmic episode. It's a very simple pathway. So when the calcium enters in the cardiac cells, it sends a signal for the ryanodine receptor to release calcium in the space. So this is the membrane, this is the sarcoplasmic reticulum, and this is the cytosol of the cell. If this channel is an abnormal channel, even during diastole it releases more calcium. This calcium is exchanged for sodium in a way that 1 calcium goes out, but 3 sodiums come in. And this sodium depolarizes the cells, creates delayed after depolarization that eventually generate the extrasystole. So just to make it simple, we have a protein that is abnormal, it's called the ryanodine receptor. This abnormality leads to this release of calcium during diastole, that to try to compensate and to get rid of this excessive calcium, the cell extrudes the calcium, exchanges for sodium, and is the flow of sodium that ultimately leads to these DADs. The fact that at the end the sodium is important, you know, we'll come back when we talk about the therapy, and we want to understand why we are using certain drugs, and these drugs are very good in preventive CPVT, or at least are very important. So I'm coming back to show you, the morphology of the arrhythmias, because I have mentioned several times the bidirectional VT. But you can also, in some patients, and you don't see the bidirectional VT, so a polymorphic VT is still also an arrhythmia that allow you to establish the diagnosis of CPVT if you see these arrhythmias regularly occurring when you put your patients on the treadmill, if you establish that the arrhythmia is present, particularly during exercise. I want to show you here the natural history of these patients, and these are data that we recently updated in our patients population over approximately 300 individuals that we are following. And what you see here, at birth, everyone is alive, but then and is asymptomatic. Very rapidly, with a quite steep line, events start occurring, so that by age 40, only little over 20% of the patients have never experienced an arrhythmic event. This is much higher than long QT syndrome, definitely many, many times higher than Brugada syndrome. And this makes of CPVT a very complex disease, in which is very important that the diagnosis is established as soon as possible. This is why I think that in this condition it's so important that the family is evaluated, because the more you move from birth, the higher is the chance that your patients may experience a rhythmic event. And the arrhythmic event may precipitate and cause actually cardiac arrest and sudden death. So early diagnosis is very, very important. It is important because we have a therapy, and therefore we are very lucky that we have a therapy for these patients. We have actually multiple therapy, but the good and important one, the one that we all implement as soon as we make the diagnosis in these patients, are the beta blockers. So this is to show you that, patient like this patient starts the recording, initiates doing exercise. This is the number of PVCs. So you see that there is a peak in the PVCs that the patient developed. But then, when the patient initiates the beta blockers, then you see that the number, even if the patient is continuous, is daily normal activity, the number of PVCs remain much, much slower. And in these patients, the arrhythmias can be very malignant even when they are asymptomatic, because remember, these are young people, they have a perfectly normally functioning heart, and therefore, their perception of the arrhythmia is much lower because brain perfusion is maintained by the fact that even at faster rates, they have a good ejection fraction, and therefore they don't rapidly perceive an inability to tolerate the arrhythmia. They may feel some palpitation, but especially young people may not pay much of attention. And this is another slide that shows you something that I consider always very important to present, is that you may have a bidirectional VT that goes on for minutes, and it seems regular, and the patients tolerate it well, but in one beat, it can immediately precipitate into VF. And this is why, you want to have these patients well treated and use your treadmill exercise stress test as a marker to establish whether you're giving them an adequate dose of beta blockers, or if the dose is already very high and top of what the patients can tolerate, if you're not enough in treating them with beta blockers. So I have mentioned at the beginning that the patients have their own threshold for initiating and manifesting these arrhythmias, atrial and ventricular. And this is an important tool that you can use for judging whether the patient is having any positive effect of beta blockers. So when you start your dose of beta blockers, you want to have at least a delay in the onset of the arrhythmias as compared to the critical heart rate at which the arrhythmia developed. So the patient used to have the arrhythmias at 90 beats per minute. You ideally would like to have these arrhythmias occurring later in time to be sure that you are giving to your patients a bigger window. Sometimes, the patient is beta blocked, so to get to the same threshold, it will exercise more. So you may not see a big delay depending on how beta blocked the patient is and how long he has been exercising before reaching that target heart rate. So there is also an antiarrhythmic effect that is not only played on the fact that beta blocker reduces the amount of calcium release from the ryanodine receptor, but also because it requires more time to reach the threshold that triggers the arrhythmia. So you have two beneficial effects of the beta blockers in these patients. And this is why, we always like to initiate with beta blockers in all the patients in which we establish the diagnosis, including the one that are asymptomatic when they come to us and they don't have very severe arrhythmias on the exercise stress test. Because we have seen patients that presented with a mild phenotype and within a couple of years, they really came to experiencing syncopal episodes, and therefore we think that we may not always be fortunate enough to have the syncope as a warning sign that that patient that had very mild arrhythmias during exercise stress test would not deteriorate and start having more severe arrhythmias. So we treat all the patients when they have the diagnosis with the genetic established test. So when we look at the guidelines, and I'm showing you the European Society of Cardiology guidelines published in 2015 in the European Heart, what they say is that CPVT is caused by arrhythmias in individuals without structural abnormalities, and exercise or emotion-induced bidirectional or polymorphic VT. So this is a summary of the criteria that you need to have to establish a diagnosis of class 1. So a very strong precision in this diagnosis, despite it's a very simple diagnosis that only requires that you do an exercise stress test in your patients. And then the second point is that CPVT is diagnosed in patients carrier of a pathogenic mutation in ryanodine receptor or calsequestrin, obviously in the other genes as well, except that we have less experience in calling pathogenic the mutation in some of the other genes, so we may have less clear-cut diagnosis. But this basically is a recommendation of class 1, very strong, that says how important the diagnosis is to contribute to your clinical management. When you need to give recommendations to the patients and decide how you want to treat them, first of all, you have lifestyle changes. Obviously, these are not patients that are in which you want to have them performing competitive physical activity. So avoidance of excessive sports or strenuous exercise should be recommended to all these patients. And, less easy to do, but also psychological stress is something that they should try to avoid. As I said, and this is a class 1 set of recommendations, that as physicians, sometimes we forget to tell the patient the little but very important thing that they can do or not do, in this case, to reduce the probability that they experience severe arrhythmias. Then the beta blockers are really the mainstay in the treatment of these patients, and should be given with the class 1 recommendations in all the patients that have documented spontaneous or stress-induced ventricular arrhythmias. Of course, there are also recommendations of lower level that would say that even the asymptomatic patients with the diagnosis are patients that may benefit with beta blockers. So when we use an ICD, there is a strong tendency to consider the ICD in patients with CPVT exactly because we know that beta blockers are good, but they are not protective in all the patients all the time. The problem with ICD implantation is the fact that not all the arrhythmias are terminated by the ICD. And you may think, yes, it's like in long QT syndrome, the arrhythmic storms. These are patients that have arrhythmias triggered by emotion. Therefore, when they get a shock, they have pain, they release catecholamines, and that triggers another arrhythmia. That is one modality. But what has been reported in the literature is that even in the absence of this vicious circle, these patients tend to have just less effectively terminated VF by the shock. And therefore, you don't want to put in a very young person an ICD unless you are relatively convinced that you have tried everything before, because in these patients, the ICD may not be all the story. So you may want to put an ICD for protection in that tough patient that does not respond well to beta blockers. But you may also have to explore other therapies, and in particular, the use of flecainide. Flecainide is a drug that we use every day for treating many arrhythmias. It was not on the top list of what one would have expected to be a useful drug for CPVT, but it turned out that actually is a very powerful tool in our hands as clinicians treating these patients, and therefore we are becoming more and more generous in the use of flecainide in those patients that during exercise stress test have complex arrhythmias at baseline. They seem protected with beta blockers, but if you push them with the exercise, you still see that they are having arrhythmias that are complex, rapid, and give you the feeling that you really want to exploit the therapy better, and therefore you're really, really encouraged to consider flecainide early on in these patients. And this, is just to say that the combination flecainide and beta blockers is becoming more and more something that is recommended by guidelines. We are not yet at the point where the guidelines say diagnosis of CPVT equal both therapies at the same time. The field, of the experts is struggling in deciding whether flecainide alone would be sufficient to treat these patients. Some attempt has been made, some recurrences have been seen. So right now the recommendation is, if you have a case that is tough, you may start with a combination. We are more hesitant to recommend this, could be a class 2A, but we are very hesitant at this point to say we can drop the beta blockers, because there is no evidence right now that that could be a safe choice. One important aspect that is important, inducibility of arrhythmias with programmed ventricular stimulation during an during an electrophysiologic study is not recommended. Actually is a class 3 that in the guidelines terms is a contraindication. So you don't gain anything in terms of your ability to predict the future of your patients in having a programmed electrical stimulation. Actually, you do something that guidelines consider not advisable for the patient. So we have discussed the beta blocker. Let's see a little bit the flecainide, and the reason why we really don't think that the beta blockers are enough for the treatment of these patients. I'm showing you two studies. One is our study. The other one is the study of the French group, Yashi's being the first author. What you see here is that both studies have compared the time 0, beginning of therapy, and follow-up. Here, same thing, time 0, initiation of therapy. And you see that, yes, beta blockers are effective. The patients without beta blocker have more events than the one on beta blocker. But the steepness of these two curves is so similar. And the results are so similar as well, saying that, in fact, you have about 1/4 of patients who fail on CPVT treated with beta blockers, and therefore they go on having syncopal events or sustained ventricular tachycardia that gives hemodynamic compromise, and they cannot tolerate it. So, or actually they die and have VF. So we really, really want to be very carefully monitoring these patients. When they are on beta blocker, be sure that if we leave them on beta blocker alone, they perform repeated exercise stress tests, depending on the patients, every year, every 6 months, until you know the profile of the patients very well. I use also the Holter because sometimes I like to have these patients monitored when they do their normal life. And in some of the patients, we really made the observation that the patients was seeming protected when he was doing an exercise stress test in the hospital, but not protected when he was chasing the bus in his normal life. So the combination of the two, until you get the feeling, yes, this dose of beta blocker is protecting my patients. I monitor it a few times and I get the feeling that there are no other arrhythmia, versus doing an intense monitoring at the beginning, of the evaluation of these patients, and right after the initiation of therapy, I get the sense that I would really like to add the flecainide. So I'm showing this specific patient just to show you that some patients are quite complicated. So these patients, as you see, is not really doing very well in nadolol despite this high dose. So let's talk a little bit of which beta blockers. The community of experts in these conditions, both long QT and CPVT in particular, we believe that nadolol is our preferred beta blockers because it has a long duration, so it removes the variability related to the compliance to multiple administration during the day. Beside that, is a highly lipophilic agent that allows to reach a very strong bradycardia in your individual, and as I mentioned at the beginning, being bradycardic is also one component of the protective effect of beta blockers, and nadolol does it right. Overall, the small series that we have recommend the nadolol above the other beta blockers, despite, as we have recently written with Mike Ackerman and other colleagues on request of the Heart Rhythm Society in the US, there is now a shortage of nadolol in multiple countries, and therefore, we need really to push for our patients to get it, and also make the authorities aware that nadolol has an edge over the other beta blockers. In terms of how much nadolol you want to give to your patient, the standard dose that the expert community recommends is 1 milligram per kilo, but I have patients that have gone much higher than that, and it's not rare that my patients actually take 2 milligrams per kilo. And of course, not all of them tolerate it, but some need it for the antiarrhythmic protection. So if at one I'm not satisfied, I push a bit higher until the patients tolerate. Some do, some do not. The one who do not, guess what? Get flecainide. This is to show you, that if you use beta-1 selective beta blockers, when you start with this big red block being non-sustained ventricular tachycardia during exercise stress test, you see that yes, even this one gives some benefit, but you reduce your enemy much better when you use nadolol. When we use flecainide, so this is to show you that flecainide has been introduced by the study of Dr. Wilde in the Netherlands when he was treating some patients very tough. So this is the patient with recessive form of CPVT. This is the patient with the dominant one. This patient is showing arrhythmia despite beta blockers and calcium channel blockers. I don't recommend to use calcium channel blockers, but at one point, it was considered as a potential addition to beta blockers. Now, nobody really uses anymore. But then they couldn't control these two patients. They added flecainide in both of them, and if blue is the area representing the arrhythmias, so here the number of ectopic beats, you see how beautifully the electrocardiogram came clean after the use of flecainide. Now, flecainide, I just want to show you here, does not abolish the delayed after depolarization, those little humps that develop when there is sodium coming in, but they actually, what the flecainide does, it prevents that these little humps become triggered beats, becomes ventricular arrhythmias, because these are formed by sodium, and the flecainide blocks the sodium that make it difficult or less possible for this depolarization to actually become ectopic beats. And I stopped there in terms of the mechanistic, but I wanted to give you the sense why flecainide is used in the patients. So this is to show you, you know, the tough patients. So these are patients that show that despite we have given them carvedilol, nadolol, and combine the two with flecainide, these patients is really, really patients reluctant to the combination of the two, and with also a very low threshold for having the arrhythmias during exercise. And look the dose of beta blocker in these patients. So don't be afraid to go up. Of course, monitor the patients. Not everybody tolerate it, but you know, you may try, and we have patients that are taking 120 milligram and they are protected. So it's not something that you can conclude the patient is not responding early on. You may go higher, and in some patients you can actually do something good. So if you have one of these patients that despite your full doses of flecainide and beta blocker that do not respond, you have another shot with cardiac denervation. Cardiac denervation, left cardiac sympathetic denervation, was first reported by Wilde with 3 successful cases. I don't think that when they went on and explored further, the results were so exciting because, you know, at follow-up of little more than 2 years, you know, 30% of the patients had a recurrent. They had an ICD implanted. So I see left cardiac sympathetic denervation not my next move on the tough patients, but something that I want to do when I have decided to implant an ICD and I want to reduce the number of possible shocks. So I may want to do the combination of ICD and left cardiac sympathetic denervation. If I think that the patient is tough, though, I don't go with cardiac sympathetic denervation alone after the patient has failed with beta blockers and flecainide. This is the patients I've shown you before. That is a patient that despite nadolol and flecainide, you know, even with cardiac sympathetic denervation, she did not respond. So all the optimal therapy that we have in these patients, you know, at this point did not work. So obviously, you may consider the ICD. You basically are forced to use the ICD in these patients, even if you know that most likely these patients might be a tough patients also for the ICD. And this is another patient. It's not the same one that I've shown you before, but it's to show you an example of patients that really do not respond well to the ICD. And clearly, every box here is the recurrence in a very short amount of time of all these ICD shocks in these patients. Obviously, I'm not trying to portray you the sensation, the feeling that these patients cannot be treated. I've actually collected a small minority of patients, mainly to pass the concept that these are not patients that after the diagnosis you can leave them home and say, come back if you have symptoms. It is really worth to keep these patients under control, check what they are doing with their exercise stress test and how they develop over time. And this is another example of an effective intervention of the ICD in CPVT, and this also in the recessive form we have seen in ineffective shocks. So clearly, CPVT is a condition where we have a lot of options. It's not common to have so many options for treatment in patients with inherited arrhythmias. We have multiple drugs, we have surgery, we have the ICD. We can combine all of the above in different ways, tailor it to your patients, his lifestyle and his age. But still we have some patients that really have a very severe disease, and you want to identify that severe disease early on and try really to exploit and play your cards to protect these individuals. But don't leave your CPVT patients alone just because after you give beta blocker, the first exercise stress test seems to give them protection. You know, follow them over time. So to conclude, typical CPVT presents with this classical adrenergical induced arrhythmic profile. The disease is highly penetrant. There are not a lot of asymptomatic, like for example, we find in long QT syndrome type 1, they have the mutation, they have the electrocardiogram marker, but they really don't have a lot of events. Here, the disease sooner or later, maybe at more adult age than adolescence, but it will give its mark and lead to a severe arrhythmic event. Beta-blocking agents, nadolol is a star. The second option is propranolol. You may try the extended release formulation in the countries that have it. The other beta blockers can be used. There is little experience with the more modern beta blockers and no big signals that they can actually give any advantage over nadolol. Side effects may be a limiting factor, so you cannot really go above a certain amount of nadolol for these patients, and so that may be the reason to force you to go early on in your follow-up of the patients to have to combine the beta blockers and flecainide. So it's very good to have flecainide also for these patients that don't tolerate beta blockers well. And the available therapeutic options reduce the arrhythmic burden. You may find for the majority of the patients at this point a solution for controlling the arrhythmias, but still, we need to find and to test and to develop better options, and several small molecules are under testing and development to treat these patients, hopefully in the near future. Thank you very much for your attention. I guess that you might have some questions.
Yeah, thank you, Professor Priori. That was terrific information. Thank you. And we've had our audience has been submitting questions during the presentation, and I'd like to remind the audience that they're able to do so by using the questions pane of their GoToWebinar control panel and clicking send. So I'll now begin reading questions that have been submitted to you, Professor Priori. Mm-hmm. I have heard of professionals suggesting cardiac screening for CPVT in infants at 50% risk. This seems not possible given the gold standard for screening is the exercise stress test. Could you please comment on this?
So I think you are asking to screen the infants. It depends, what is the history of the infants. If the infants are the infants of a mother with or a father with CPVT, definitely early screening is the best way. You don't want to waste your time in performing a lot of electrocardiogram recording in an infant, and just go with the genetic screening. Otherwise, the screening in all the infants is not something that is really recommended, even if it's true that, a relevant proportion of the sudden infant deaths of arrhythmic origin, so not all the sudden infant deaths, but the one of arrhythmic origin, may have a CPVT as a substrate. But I don't think that at this point, the screening to prevent sudden death in family that don't have an excessive risk or an evidence of CPVT is the recommended approach.
All right, thank you. In your personal clinical practice, at what point do you recommend an ICD? I understand that you likely would have the following strategy: beta blocker first up to maximum tolerated dose. If there's still an arrhythmia, you then add flecainide and consider sympathectomy. And if all of these therapies fail, you consider ICD as the last resort. Is that correct?
Well, as I said during the presentation, I do beta blockers. The second step is definitely flecainide. If I'm not satisfied about flecainide, I go to the ICD. So the ICD is my third step. I may consider to do also denervation when I implant the ICD in the patients where I know that these patients have very frequent occurrence of rapid VTs, polymorphic or bidirectional, but that may actually lead to early shocks, maybe shocks on arrhythmia that would terminate and therefore should be called inappropriate, or just an excessive number of shocks. And so I really would like to play the last card in adding the denervation. But I'm not really convinced. I'm definitely not doing that. If I think that after flecainide my patient still has ventricular arrhythmias that are sustained over time when they do exercise, I want to go with denervation. I go to the ICD.
Great, thank you. What is the youngest age that you have done a treadmill test with?
We do the treadmill test. Of course, it depends on the child, how balanced they are. But we put them on the treadmill when they are 4 or 5. The treadmill goes slow, and when they are accustomed, we go faster. And the nurse is behind the child with the feet on the part that is not moving, the two little lines of plastic where the treadmill is running. So in case the child loses balance, she can stop the treadmill immediately and catch the child. But usually, if you start slowly, you can do it in that. Obviously, at that age, and even younger kids, we use the Holter or the 7 days monitoring more than we do the exercise stress test.
Thank you. Why do you think some cardiologists do not encourage or recommend genetic testing for their patients and families?
Honestly, I don't know. In the past, there was a problem with reimbursement that was very, very strong. So some physicians were frustrated of trying to get the reimbursement for their patients and not getting that. But now the situation has changed. So I think that genetic testing is not something that you can be in favor or against, because it's not one category. Actually, it depends genetic testing for which disease. And as a physicians, we should be aware of the fact that in some disease, the genetic testing is giving you a tremendous help, because you have two conditions. One, you have a high percentage of your patients that can be genotype positive with a conclusively pathogenic mutation. Then you know that you can use that results to screen the family. That result for having established conclusively the diagnosis in your patients is you were not sure of the result, and is really, really something that is a winning point. If you talk about conditions in which the yield, so the number of patients in which we find a mutation is very low, and after you have found the mutations, you manage the patients exactly as you would manage that patients before having the mutation, and you're not sure whether there is an advantage in screening the family members as well, because if you establish the diagnosis in an asymptomatic individual, there is nothing you could do, then it's okay that you want to discuss. But being in favor of against genetic testing means not having really understood well that is the judgment on in which level of your practice you have to put the genetic testing as a resource for you is different from each disease. And I have no doubt, for example, that in CPVT, but also in long QT, is a tremendous help for me when I practice every day. Impossible to be against.
Yeah.
Really.
Thank you. What is your threshold for acceleration of medical therapy based on exercise test results? By Gemini, couplet, something else?
Yes, no, I actually, the occurrence of PVCs and bigeminal that do not aggravate over the following part of the exercise stress test don't really create a lot of concern in me. It really frequent runs of non-sustained VT is the thing that most frequently make me feel that, that patient is having 4 beats, very rapid, very irregular. If they have the polymorphic VT, for example, after 3 sinus beats, they have another run, and then 3 sinus beats and another run. I consider that substrate a substrate that could really degenerate, and therefore I move to the next step, whatever that is.
Thank you. Would you treat a survivor of cardiac arrest with only PVC during stress who has an RYR mutation that has been labeled as a VUS as CPVT?
So we have a cardiac arrest, right, at the beginning. Is that what you read?
Yeah, survivor of cardiac arrest that only had PVCs during stress, but they have an RYRT mutation that's been called a variant of uncertain significance.
So in these patients, what I know is that he has had a cardiac arrest. presumably, if we have a result of genetic testing as a variant of unknown significance and we have few PVCs, we say it's still probably a CPVT, but is not conclusive, so I move forward in doing all the other tests that I would like to do in a survivor or cardiac arrest, depending on the age, but definitely I want to have an angiography, for example, just to, otherwise the patient, you know, is classified as an individual with idiopathic VF. And the diagnosis of idiopathic VF requires that you exclude also with angiography that they have an abnormality in the coronary artery. So I would do that and I would finish. I would maybe, depending on the condition in which the patient had the cardiac arrest, also do my sodium channel blocking test to exclude that is a Brugada. I maybe extending the panel to other channelopathies if the heart is structurally normal to see if the patient has other things. But after having completed the diagnostic pathway, I think that unless I find something that is either reversible or, you know, something that you can really treat in a completely different way because you resolve the situation, like if you have a coronary artery disease, you take care of that. I would still put an ICD in these patients, and I would probably add a beta blocker because still I would like to get rid of those PVCs and try to make sure that if the patient in the real life develops more than isolated PVC in response to exercise, he is protected. But the thing on which I would not deviate is the fact that a survivor of an explained cardiac arrest without another conclusive diagnosis requires an ICD anyhow.
Thank you. Do you titrate your medical therapy based on ventricular arrhythmias only, or do you change medical therapy based on the presence of atrial arrhythmias as well?
The atrial arrhythmias are interesting for one aspect, that there is an hypothesis that has never been confirmed that when the heart rate is faster in the patients, we know that it's easier to precipitate the ventricular arrhythmias. So the atrial arrhythmias may be seen as an accelerator of the rhythm that, being themselves innocent, they may, by making the heart beating faster, precipitate the ventricular arrhythmias. However, you know, right now there is no evidence, no data that by suppressing the atrial arrhythmias is a target of therapy, and therefore that we really want to try to prevent the occurrence of these arrhythmias if the patient is not manifesting ventricular arrhythmias. So right now, the change in the therapy that we do is based on the ventricular arrhythmias because we have really no evidence, conclusive evidence, that reducing the atrial arrhythmias is really something that directly will impact the number or severity of the event of ventricular arrhythmias.
Thank you. We've had a few questions around variants of unknown or uncertain significance. So I'm going to kind of combine those together with how do you handle a situation in which the genetic test shows a missense mutation in the ryanodine receptor that has been classified as a VUS?
Yeah. So the variant of unknown significance are really, you know, the difficult part and the difficult question. So I tend to say that if the diagnosis is a variant of unknown significance, as a clinician, I'm not entitled to consider these as a part of my clinical management because exactly for what as the name says, you know, we don't know how to handle that. So what I do, I try to manage the patient from a clinical point of view and decide, you know, whether the event occurred, what is the event that led to this genetic testing. Of course, if it was a cardiac arrest, I recommend an ICD. If the patients had the event during exercise or emotion, starting reaction or so, I try to have the patients beta blocked. Of course, I measure the QT, I do the Brugada testing. I try to exploit my clinical phenotyping capacity. And I just disregard the result of the genetic testing, waiting that maybe in the future there will be some other information on that specific mutation. Actually, being also a group that does genetic testing, we are provider for the Italian system of genetic testing for these conditions. I consider the variant of unknown significance differently, and for example, if they have a frequency in the population that is quite high, I tend to be more convinced that the variant is benign, as opposed to if there are other factors that have led to an inconclusive, for example, the in silico simulation, like the test like siftepolifen. So this is just to say that there are two levels, the physician cardiologist, who is not also geneticist, takes the variant of unknown significance, and I think that the right approach is to say this test is not usable at the clinical level at the present moment. So I just say I cannot benefit of the help of genetic testing in this specific patient, even if, in other patients for this condition, genetic testing is very useful, but in this one I have to do without. If you are, playing with genes and interpretation of variants, you may have few other hints that allow you to customize the results. But still, I think that the variant of unknown significance is what the geneticists call a non-actionable result. So basically, there is nothing you can do except explain to your patient that the test cannot be applied to him. And I would like to make a comment on this. Since telling the patients the result came back, but we don't really understand, you have something, but we don't know what that is, maybe quite upsetting in the patients. Every time I offer the genetic testing to the patients, I say there are three possible results: positive, negative, and unknown. And I explain to the patient that if it's unknown, it means that it's just a result that we cannot use, so that the patient get acquainted to the concept that it doesn't have to panic if they have something that we don't know what it is.
Thank you, Dr. Priori. We've reached the end of the hour, and I'd like to thank you for sharing your insights with all of us today. Are there any concluding remarks that you'd like to make? For some reason, they seem to have gone on mute. All right. For those who are still with us, we've reached the end of our hour. Thank you very much for attending today.